We start the brachial plexus today. This is the first rib. You are seeing it from above. On it are inserted the scalene muscles. So here is the insertion of the scalene anterior, making it like this. Here is the insertion of the scalene medius, making it like this. And the scalene posterior muscle actually goes across the first rib and gets inserted onto the second rib. That is the boundary of the second rib that you are seeing. Now, the brachial artery comes from here and crosses into the posterior triangle and then into the axial. Here is your brachial artery. You'll actually color it so that you can see it clearly. So this is the brachial artery. And here is the subclavian vein. This is the subclavian artery and this is the subclavian vein. Now above from between the scalene anterior and medius and above the artery arises the brachial plexus, and it spreads round the lateral, medial and posterior side of the artery. So the brachial plexus basically lies between the scalene medius and scalene anterior. From the brachial plexus, one nerve goes across the scalene anterior into the thorax, and this nerve is called as the phrenic nerve. Another nerve goes to the subclavius muscle, which is going to get inserted into the clavicle. So this is called as the nerve to subclavius. So it's inserted into the clavicle. And now this nerve, the nerve to subclavius, is a branch which hooks around the vein, and joins the phrenic nerve. So there is this sling which is formed, which hooks the subclavian vein. So here is the subclavian vein. It is being hooked by this nerve, which is arising from the nerve to subclavius and joining the phrenic nerve, which is lying on the surface of the scalene anterior muscle. So this hooking of the nerve leads to stasis in the region and clotting in the region because of the stasis. And this is responsible for this nerve, which is called as the accessory phrenic nerve. The branch of nerve to subclavius and going to join the phrenic nerve hooks the subclavian vein, causing spontaneous axillary vein thrombosis. So that the veins of that upper limb become dilated, tortuous, and associated with pain and swelling. For this, the treatment is that you have to section this accessory phrenic nerve and you have to recanalize the subclavian vein. So this is the placement of the brachial plexus. This is the placement of the brachial plexus. Now we will go on to describe the structure of the brachial plexus, formed from the 3, 4, 5, 6, 7, 8, 1 roots, 5 and 6 forming the upper trunk, 7 forming the middle trunk, and 8 and 1 forming the lower trunk. The upper trunk divides into anterior and posterior divisions. All these trunks divide into anterior and posterior divisions. The posterior divisions of the 3 form the posterior cord. Anterior division of the middle and upper trunk form the lateral cord, and the anterior division of the lower trunk form the medial cord, lateral cord and posterior cord. Lateral cord continues as the musculocutaneous nerve, the posterior cord as the radial, the medial cord as the ulnar, and both medial and lateral cord give rise to the median nerve. After understanding the structure of the brachial plexus, let us enumerate its branches. The branches are from 3, 4, 5, you have phrenic. The branches are from the roots, and the 3, 4, 5 roots give rise to phrenic. 5 to dorsal scapular or nerve to rhomboids. And 5, 6, 7 nerve to serratus anterior. Besides this, 3, 4, 5, 6, 7, 8, 1 roots give rise to nerve to scalenus anterior, medius and posterior, and all give branches to rami communicants. So you have to say 3, 4, 5 phrenic, 5 dorsal scapular or nerve to rhomboids, 5, 6, 7 long thoracic or nerve to serratus anterior, and all to scalena anterior, medius and posterior or rami communicants. You have to remember this by heart. Then from the trunk, from the upper trunk, there arise 2 nerves, the suprascapular and nerve to subclavius. Anterior posterior division join. Anterior posterior division are created from the upper trunk. 5 and 6 nerve roots join, and suprascapular and nerve to subclavius make 6 nerves which come out from this point, and this point is called as Erb's point. Then no branches from the divisions, but the branches from the cords. If you want to remember, it is simple. There is the lateral cord, there is the medial cord, and let us say this is the posterior cord. The lateral cord, musculocutaneous nerve, medial cord, ulnar nerve, posterior cord, radial nerve, and median and lateral cord, medial and lateral cord, median nerve. Besides this, we add lateral and medial pectoral, lateral, medial, pectoral from the lateral and medial cords. Pectoral means supplying the pectoralis major and minor nerves. And from the posterior cord, you have an upper subscapular, you have a lower subscapular, you have a nerve to latissimus dorsi, and you have axillary. So upper, lower subscapular, nerve to latissimus dorsi, and axillary nerve, which goes and supplies the teres minor, the deltoid, and the regiment batch area of skin under the acromion process on the shoulder. So these are the branches of the brachial plexus. Now we start dealing with the applied anatomy of these branches. So the first applied importance is that 3, 4, 5 phrenic supplies the diaphragm. So any injury of the cervical spinal cord above 3 paralyzes the phrenic nerve and paralyzes the diaphragm. It also paralyzes the intercostal muscles, and therefore there is respiratory arrest, and any lesion during the injury or after the injury which crosses the C3 cervical level is incompatible with life. The patient will die before he can reach the hospital, unless and until he is extremely lucky to be put on a ventilator on the roadside. The second is 5, which is dorsal scapular, and we do not have much applied importance about the dorsal scapular. The third is 5, 6, 7, which is the nerve to serratus anterior, and the serratus anterior is a muscle which, if this is the scapula seen from above, Here is the head, the lesser tuberosity, the bicipital groove and the greater tuberosity. And here you have a muscle which arises from the medial border and gets inserted on the ribs. So these are the ribs, and this muscle will pull the scapula forward. The movement is called as protraction. The other muscle, rhomboids, will pull the scapula backward, which is called as retraction. So the nerve to serratus anterior supplies the serratus anterior, and if this nerve is paralyzed, if you use the upper limb to push forwards, then the scapula will not be retained against the thorax but will be pushed backwards, and that is called as winging of the scapula. Now, above the scapula you have a process which is a finger-shaped process like this, and here you have the suprascapular notch, and this process is called as the coracoid process. So from the coracoid process you have three muscles, the coracobrachialis and the short head of biceps going to the arm, but pectoralis minor coming to the chest wall. So you take off the pectoralis minor from the coracoid and you arch it backwards, arch this muscle backwards and attach it to the scapula. So the pectoralis minor will take the function of the serratus anterior. So this is winging of the scapula, the physical sign. Paralysis of the long thoracic nerve of the nerve to serratus anterior, and treatment by pectoralis minor transfer to the serratus anterior finishes off the 5, 6, 7 story. Now we say go on to all, and all supply the scalene muscles, but they also send rami communicants to the sympathetic trunk. So if you are looking at the first rib from the front, here is the first rib, here is the manubrium sterni, here will be the clavicle. So if you are looking at the first rib, here will be the transverse process of the thoracic vertebra, and here will be the vertebra itself. So this is the T1, and from it is arising the first rib. So the first thing that you will see is that attached to its medial border is what is called as the suprapleural membrane, which covers the pleura. The problem with this suprapleural membrane is that if it is ruptured, you enter the pleura. You are very careful with putting any needle or anything here. Then, lying on the above and below, above the suprapleural, above the neck of the first rib is the inferior cervical ganglion, the middle cervical and the superior cervical sympathetic chain. Superior, middle and inferior cervical sympathetic ganglion, and below is the first thoracic. So what happens that these two join and they form what is called as the stellate ganglion. Now from this, the sympathetic supply goes to the head and neck and also to the upper limb. So when there is this vascular insufficiency, in the upper limb, then you get the physical signs of 5 P's: pain, pallor, pulselessness, paresthesia, paralysis, and you can quantify the vascular insufficiency by a pulse oximeter. The causes of vascular insufficiency are remembered by the formula of RESTED, rested. R for Raynaud's, E for embolic, S for senile, T for thromboangiitis, obliterans or Berger's disease, found in males, smokers. E again for ergot alkaloid poisoning. This ergot alkaloid was found on a fungus called Aspergillus niger, which used to grow on rye. People eat rye, and this was prevalent near the church of Saint Anthony. So people used to get gangrene near the church of Saint Anthony, and people used to think that this is because they were bad and Saint Anthony has punished them. That was also called as Saint Anthony's fire. Disease was called as Saint Anthony's fire, but basically it was because of this ergot alkaloid produced by Aspergillus niger, which grows on rye, which people used to eat near the church of Saint Anthony. So this is ergot alkaloid poisoning. And D is a very common condition which is called as diabetes. Now, besides this, vascular injury can produce vasospasm, or there can be external pressure on the blood vessels. Chronic external pressure can be by, let us say, cervical rib or scalenus anticus syndrome, and otherwise the pressure can be by a fracture bone or dislocated joint. In the upper limb, the supracondylar fracture humerus is responsible for the most of vascular insufficiency. Vascular insufficiency can also be iatrogenic when bamboo sticks or chips are used to splint both bone forearm fractures by quacks. So these are the reasons of vascular insufficiency, and the first step is that you remove all external pressure, extend all joints. You can see that if you flex the elbow too much, the radial pulse will disappear. So you have to extend all joints. You can confirm that the radial pulse will disappear if you hyperflex the elbow. So you extend all joints. Then you give things that will prevent clotting, like percentin or heparin, and then or aspirin. Then you try to decrease the vasospasm, and this you do by sympathetic blockade. And here you inject local anesthesia, phenol or carbolic, or botulinum toxin into the stellate ganglion. Being very careful that you don't inject them into the pleura, because this suprapleural membrane or substance fascia is just above the pleural cavity of the lung. So you inject this and you see reversal of 6 P's: pain, pallor, pulselessness, paresthesia, paralysis, and pulse oximeter. And besides this, by the head neck component, you see 3 eye signs, eye signs are, first thing is ptosis, because the levator palpebrae superioris smooth muscle component, which is called as Muller's muscle, is paralyzed. Second is miosis, the pupil constricts because the dilator pupillae is paralyzed. And the third thing is that the eyeball, if you see this eyeball here, this is the optic nerve, and here is the lacrimal part of the orbicularis oculi muscle, and this lacrimal part gives a smooth muscle part to the eyeball, which keeps on pulling the eyeball forward. This is called as the Horner's muscle. And this Horner's muscle is producing X ophthalmos. So here you have the third physical sign because of paralysis of this Horner's muscle, and that is N ophthalmos. Now we'll try to show you the Horner syndrome so that you can revise these physical signs. So we go on to the chrome. We say Horner's syndrome. We look at the images, and I think the best image which shows is this. You can see ptosis, meiosis. You can see meiosis here. Compare the size of the pupil, and N ophthalmos. Besides this, what you see, that the half of the face is redder as compared to the other side because of vasodilatation, and this is called as the flag sign. So, flushing of face. And finally, what you can demonstrate is anhidrosis, no sweating on this side, by painting the forehead with starch iodine and causing sweating by putting a 100-watt bulb on the face of the patient. On the side that there is no sweating, the paste will remain white. On the site where there is sweating, the sweat will dissolve the iodine, make it react with the starch, and that side will turn purple. So Horner syndrome, which you see here, is marked by ptosis, meiosis, anophthalmos, flushing of face, and anhidrosis. So after this, we return to the sympathetic component. We finish off the rami communicants component of the brachial plexus. Now we go on to the trunk. The trunk gives a suprascapular nerve and nerve to subclavius. We have already covered that some fibers from the five going to the phrenic nerve, instead of straight away going to the phrenic nerve, hike on the fifth root, go to the upper trunk, hike on the nerve to subclavius, become the accessory phrenic, hook the subclavian vein and meet the phrenic. This hooking action can produce constriction of the subclavian vein, stasis, and spontaneous axillary vein thrombosis. We have already covered this. Now let us go to the suprascapular nerve. The suprascapular nerve goes back, passes through the suprascapular notch, under the transverse scapular ligament, and as it goes behind the scapula, it not only supplies the supraspinatus but passes through the spinoglenoid notch and supplies the infraspinatus as well. So supraspinatus, infraspinatus. Now what does the supraspinatus do? You see, if this is the head of the humerus, this is the greater tuberosity and the bicipital groove, and here is the acromion, and the deltoid is coming and getting inserted like this. So this deltoid will in the initial stages, in adduction stage, will simply pull the humerus up. It will not abduct it. So the abduction is initiated by the supraspinatus, by the supraspinatus muscle. So first 15 degrees of abduction is initiated by the supraspinatus muscle, and then the deltoid takes over. So now this supraspinatus is paralyzed, and therefore the person would basically rotate the scapula so that the glenoid starts pointing upwards, and then now since this humerus has become angulated, then this deltoid will be able to take over. So this is called as reversal of the scapulohumeral rhythm. Normally the scapula doesn't move up to 90 degrees of abduction, but here the scapula must move to initiate abduction, and this is called as reversal of the scapulohumeral rhythm. This paralysis or inability of the deltoid to abduct the shoulder in adducted position is so important that this needs to another reversal, and that is, if the shoulder is replaced, the glenoid must become the ball and the upper end of the humerus must become the socket. So the ball socket reversal occurs in total shoulder replacement to allow the deltoid to start acting in abduction. So this is the reversal of the scapulohumeral rhythm that you have noticed with the suprascapular nerve. Now in obstetrics, the whole of the upper trunk, 5-6 joining, anterior posterior division, suprascapular and nerve to subclavius, pulled because of pulling the head while the shoulder is fixed during birth. So this causes an obstetric paralysis, and this paralysis is called as Erb's palsy. Now in this Erb's palsy, if this is the neck, this is the shoulder, so there is adduction of the shoulder, failure to flex the elbow, pronation of the forearm, and palmar flexion of the hand, which is called as typically the policeman tip taking position. Shoulder adducted, fails to abduct. Elbow fails to flex. Forearm fails to supinate. And wrist fails to dorsiflex. So the child is born with the policeman tip taking position, and you have to reverse the adduction. So you reverse the adduction by abducting the shoulder, flexing the elbow, supinating the forearm, and dorsiflexing the wrist. And the position that is gained is policeman's top position. And you splint in this policeman's top position to prevent contracture. The second thing is till there is recovery, you have to maintain muscle tone. Now for maintaining muscle tone, the muscles are, of course, deltoid, biceps and brachialis, flexors of elbow, supinator, but biceps is also a supinator, and then dorsiflexors of wrist. So anything to do with wrist has carpi in between, and dorsiflexor means extensor, and these extensor carpi are radialis and ulnaris, and the radialis attached to the first metacarpal is longus, and the second metacarpal is longus, and the third metacarpal is rectus. So these are the dorsiflexors of the wrist that are paralyzed, and you have to maintain the muscle tone of these. For that you have to understand what is called as the strength duration curve. The strength duration curve. Now the muscle and the nerves are irritable. Both are irritable. But if this is the nerve and this is the muscle that it is supplying, and this is the myoneural junction is also called as the motor point, then the nerve can respond by a stimulus, by an electrical current, which is lesser than 3 millisecond duration. So a current which is lesser than 3 millisecond duration. Here is the current coming, and this is these pulses are less than 3 millisecond duration. This current is called as Faradic current. And nerves can get stimulated by Faradic current. So if the nerves are lost, then you have to give a greater than 3 millisecond duration current to be able to stimulate the muscle directly. So that is called as galvanic current. So any muscle, you put an electrode at the myoneural junction, and if the contraction is occurring by a current which is greater than 3 millisecond, it is called as state of galvanism, and it means that the nerve supply to that muscle is absent. But if it can get stimulated by less than 3 millisecond current, it is called as the state of Faradism, and that means nerve supply is intact. Now, by this strength duration curve, you have to remember two other names. You start by greater than 3 millisecond current somewhere here, and you go on increasing the current till you get a contraction. Your electrode is at the myoneural junction. When you get the contraction, this minimum strength of current which can cause a contraction is called as Rio base. Minimum current which can cause a contraction. Now, you take twice the Rio base, 2 times the R, and go on decreasing the duration. If the muscle, if it is a state of galvanism, that means no nerve supply, then you will get increased strengths needed for contraction, and by a current less than 3 millisecond, you will not be able to produce a contraction. So this is no nerve supply phase. or galvanism phase or only muscle phase. Now as the muscle starts recovering, there is a notch that appears, and and this curve becomes notched like this, and then gradually this notch goes on shifting up to this place, and you finally find a response like this. This is a Faradic response, and the movement from the galvanic to a Faradic response is called as reaction of regeneration. So how do you make the paralyzed muscle contract? Initially by galvanism, galvanic current. Then by Faradic current. And then after the muscle is actively able to contract itself by the nerve, then you can have active assisted exercises, active exercises, neither assisted nor resisted, and then finally active resisted exercises. So this is the pattern that you follow as nerve recovers, and nearer the muscle, earlier the recovery. So the sequence will be deltoid, brachialis and biceps, and then supinator, and then wrist dorsiflex. And this is called as the motor march. Same way there is a sensory recovery, and that is called as the sensory march. And if you tap on the nerve, there is tingling distally, which is absent beyond a certain point. So if the nerve is intact up to here, there will be tapping will produce tingling up to here, and then it will become absent. So this is called as Tinel's sign. Electrodiagnostically, if the nerve is absent from here, then there can be three stages. The axons degenerate beyond this point, and this degeneration is called as Wallerian degeneration. And then there can be axons structurally intact structurally, but functionally lost. So this stage is called as Neurapraxia, only function lost. And axon degenerated, if there is a section, will not recover without surgical suture of the nerve. But if the sheath is intact, then if the sheath is intact, not sectioned, then it is called as axon atomesis. That means sheath intact, only axons lost. Then they will grow at the rate of 1 millimeter per day, crossing 3 days to cross a joint. And they'll go on recovering till they reach the myoneural junction. Now, the myoneural junction will wait for them for 9 months. After that, the junction will become fibrosed, and even if they reach the muscle will not recover, and that is called as residual paralysis. Now, so usually in Erb's palsy, it is axonotmesis. So there is no sectioning of the nerve, it is basically stretched, and usually there is recovery like this. Now to shorten this recovery, you have the brachialis, the biceps muscle, and under this biceps you have the brachialis. This is the brachialis and this is the biceps. And there is a muscle which is called as coracobrachialis on the medial side of arm. So the musculocutaneous nerve is arising from the lateral cord, piercing the coracobrachialis, supplying it, and then giving a branch to the brachialis and the biceps, and then becoming the lateral cutaneous nerve of forearm. So it's becoming the lateral cutaneous nerve of forearm, supplying the skin, and that's why it's called as musculocutaneous. Muscles in the arm and cutaneous in the forearm. Now, there are two important and big nerves. One is the median, lying on the lateral side of the artery, and the other is the ulnar, lying on the medial side of the artery. Now you can take trunks from the median and the ulnar. You can section the musculocutaneous near the brachialis, here and here, and you see there are no axons. So these nerves, trunk that you take will have axons, and you can reattach the nerve trunk of the median to the biceps and of the ulnar to the brachialis, so that very near the muscle you have put axons, and this will cause recovery of the biceps and brachialis, and the operation is called as the Oberlin operation. So this is what you do in the recovery phase of the Erb's palsy, and when there is residual paralysis, then for deltoid you put in trapezius, because trapezius is responsible for overhead abduction of the shoulder. For the biceps, since the biceps flexes the elbow and supinates, so you try to reconstruct the biceps, and biceps has a long head and a short head. The long head arises from the supraglenoid tubercle and the short head from the coracoid process. The other muscle that is arising from the coracoid process is pectoralis minor, and this pectoralis minor is being supplied by the medial pectoral nerve, not paralyzed in the Erb's palsy. So you use the pectoralis minor to substitute the biceps and restore elbow flexion and supination simultaneously. Then for the wrist dorsiflexors, all of you pronate you try to dorsiflex your wrist when you are writing, and you find that your hand pronates. So pronation of the forearm and dorsiflexion of the wrist are synphasic, they occur in the same phase of function. So for the wrist dorsiflexors, you substitute pronator teres. And this is the entire management of Erb's palsy. And next time we will move to telling you about branches from the cords, and then we'll continue with the major nerves, the musculocutaneous, the median, the ulnar, and the radial. Now move on to the lower trunk. Lower trunk is formed by the roots of C8 and T1. Under it rise the first rib. Anterior to it is the scalnus anticus muscle. And behind it is the scalnus medius muscle. So it is between the scalnus anterior and the scalnus medius. Now, if there is a cervical rib above the first rib, this is the first, and this is the cervical rib, then the C8T1 root will be stretched. And as you get older, the shoulder, instead of a good trapezius tone, you have a poor trapezius tone, so that the shoulder sags. Now, as the shoulder sags, there is a pull over this C8T1 root. Now, if the C8T1 is involved, basically the C8T1 supplies the lumbricals L1, L2, L3 and L4. The L1 and L2 are supplied by the median nerve, and the L3 and L4 are supplied by the ulnar nerve. So, if there is a combined medial ulnar nerve paralysis, L1, L2, L3, L4 will be paralyzed. Now, I want you to understand that the metacarpal is here. The lumbrical will flex at the MP joint because it is arising from the flexor digitorum profundus. So here is the first interphalangeal joint, here will be the second interphalangeal joint, and this FDP is attached to the distal interphalangeal joint. The FDS is superficial to it, but it splits into two and is attached to the middle phalanx. Now behind this is the extensor expansion, which attaches like this and then goes and combines and attaches to the distal phalanx. So here is your extensor expansion. The extensor digitorum longus along with indices and digiti minimi is attached to the extensor expansion and is responsible for extension of the MP joint. The lumbrical muscles arise from the FDP and attached to the extensor expansion. Therefore, they would flex the MP joint. So they would flex the MP joint, and through the extensor expansion they will extend the PIP and DIP joints. The lumbrical muscles are therefore muscles that are called as musician's muscles, for they will tap the tabla and produce sound. So lumbricals put the fingers in this position. If this is the other finger, this is the third finger, this will put the finger in this position, and this position of MP flexion and PIP DIP extension is called as intrinsic plus position. Now, if the lumbricals are paralyzed, opposite of this will occur. That means if this is the metacarpal the MP joint will extend and the PIP and then DIP will flex, and this is the position of claw hand. So in median paralysis there is clawing of the L1 and L2. In ulnar paralysis there is clawing of the L3 and L4, and in C8 T1 lesions there is clawing of L1, 2, 3 and 4. Besides this, in C8 T1 lesions the medial cutaneous nerves of arm and forearm also get paralyzed, and therefore there is sensory loss in the medial aspect of arm and forearm. So this is the differential diagnosis of C8 T1 lesion of Klumpke's paralysis. They are involved in cervical rib. They are involved in scalenus anticus syndrome. Scalenus anticus syndrome. So this is C8 T1. After covering the roots and the trunks, the brachial plexus moves into the infraclavicular region, where we have the lateral cord and the medial cord, giving rise to lateral pectoral and medial pectoral. The medial cord giving additionally the medial cutaneous nerve of arm and forearm. Both, and we have the posterior cord, which gives rise to upper, lower, subscapular, latissimus dorsi, axillary. So pectoralis major will show wasting in the pectoral involvement. And you can't see the subscapularis. Latissimus dorsi is the muscle which is called as the climbing muscle. It flexes the arm in overhead abduction. So in pull-ups you use the latissimus dorsi, which may become weak, and axillary nerve is diagnosed by deltoid paralysis or paralysis of the teres minor, but that's not seen. So you see a sensory loss in the regiment batch area of the skin below the acromion. So that is the upper lower subscapular, the thoracodorsal, the axillary. Now, other reasons of lower motor neuron paralysis. Upper motor neuron is from the cortex to the spinal cord, and the lower motor neuron is from the anterior cell, the nerve root, the nerve, the myoneural junction, the muscle. The anterior horn cells are involved in poliomyelitis and motor neuron disease. Poliomyelitis is acute, motor neuron disease is chronic. Nerve root is basically involved in spina bifida, also called as spinal dysraphism, failure to unite, and is involved in prolapsed intervertebral discs. Now, nerve involvement is of three types: mononeuritis, mononeuritis multiplex, and polyneuritis. Myoneural junction is involved in myasthenia gravis, and muscle involvement is in muscular dystrophy. So this is the differential diagnosis of lower motor neuron involvement. You would appreciate that in the nerve root and in the nerve involvement, there will be sensory paresthesia, hypoesthesia, or anesthesia, because they have both motor and sensory fibers. So after completing the brachial plexus, we will move on to its major nerves: the musculocutaneous, the median, the ulnar, and the radial.